Hello, and welcome to the Center for Connected Health Policy's Telehealth Policy webinar series, Crossing State Lines. My name is May Kwong. I'm the Executive Director at the Center for Connected Health Policy, and today we'll be talking about issues that you need to consider if you are crossing state lines to provide healthcare services via telehealth. Before we get started, a couple disclaimers and friendly reminders. Know that any information provided in today's webinar is not to be considered legal advice. It is strictly for informational and educational purposes. If you are interested in a formal legal opinion, please consult with legal counsel. Also know CCHP has no relevant financial interest, arrangement, or affiliation with any organizations related to commercial products or services that may be discussed in today's program. Today's webinar is being recorded, and the slides and the recording will be made publicly available on CCHP's website and through our YouTube channel. Today, closed captioning is being made available, so if you will look down on the toolbar in Zoom, you'll see a closed caption option for you. We also ask that you please refrain from any political statements or advertising commercial products or services during the webinar. This is to remain an educational session, so we ask that you do not do any of those things such as making a political statement or advertising services. Please note that if you have a question for our panelists today, please use the Q&A function. The chat function should only be used if you are having technical difficulties with Zoom. Again, the Q&A function is for questions for the panelists, so we ask that you use that. A bit of background about CCHP. We were established in 2009 as a program underneath the Public Health Institute to actually act as a California telehealth policy organization. However, an opportunity to become the federally designated National Telehealth Policy Resource Center became available through a grant from HRSA in 2012. CCHP applied for that, received the grant, and have been serving in that capacity ever since. CCHP also works with a variety of other funders and partners on the state and federal levels on various telehealth or connected health projects. CCHP also acts as the administrator for the National Consortium of Telehealth Resource Centers. The National Consortium is made up of the 14 telehealth resource centers who are funded underneath the same program as CCHP. There are 12 regional resource centers that cover specific states, and they offer that program operational, boots on the ground, telehealth technical assistance. There are 2 additional national centers, one on policy, which is CCHP, and the other one on technology. You'll be hearing from one of the regional telehealth resource centers today, that is the Mid-Atlantic TRC. But feel free to go to CCHP's website or the consortium's website in order to find out which telehealth resource center covers your region or your state. And finally, CCHP also acts as the convener for the California Telehealth Policy Coalition, which is a coalition of over 165 state and national groups who are interested in telehealth policy in the state of California. And as I said, this was the information regarding the National Consortium. As you can see, there are 12 regionals that cover specific states. So you can go to CCHP's website to access which TRC covers your state, or you can go to the National Consortium's website. So just to let you know, our fall series will actually only be 2 webinars this time. The next one is for federal policy and what to be aware of as we move forward and out of the pandemic. The registration link is open for that, so feel free to go ahead and sign up for that as well if you have not already. But for today's webinar, we have with us a great lineup of panelists to talk about various issues that you will encounter if you're trying to provide services via telehealth, but crossing state lines. Telehealth, as most of you know, is a wonderful tool to provide services that really eliminates the distance and distance barriers of trying to provide services to a patient when the provider may be located somewhere else. So really, it kind of makes borders insignificant because you can use technology to provide the services. But however, those borders as far as policies, laws, and regulations that you need to abide by still exist. So what do you do in that situation? And we're going to talk about some of those things, some of those particular issue areas to be aware of, and sort of some of the solutions that may have been offered or put in place to address some of those issues that providers may encounter when crossing those state borders. So we're going to cover such issues such as licensing, reimbursement, and practice requirements, among other issues as well. So we are joined today by Kathy Wibberly, who is director of the Mid-Atlantic Telehealth Resource Center, Kim Horvath, who is a senior attorney with the American Medical Association, and Jeremy Sherer, who is a partner at Hooper, Lundy, and Bookman. We are going to hear first from Kathy, who, as I said, is with Mid-Atlantic Telehealth Resource Center. Kathy Wibberly is the director there. TRCs are federally funded to assist with telehealth program development and sustainability in order to increase access to quality care for rural and other underserved populations. Kathy is also director of research for the Karen S. Ruban Center for Telehealth, assistant professor of public health sciences at the University of Virginia School of Medicine, and faculty member at the Healthy Appalachia Institute. For over a decade, Kathy has served as adjunct faculty in the L. Douglas Wilder School of Government and Public Affairs at Virginia Commonwealth University, where she taught research methods. And she also has a public service career that reflects over 30 years of experience in public health, public policy, program development, program evaluations, and strategic planning. Kathy is an appointed member of the chair of Rural Health Committee for USAC and is vice president of the Virginia Telehealth Network Board. She received her BA in psychology with minors in pre-medicine and youth services from Gordon College in Wenham, Massachusetts. And she received her MS and PhD in counseling psychology from Virginia Commonwealth University in Richmond, Virginia. Kathy has a certificate from the Management Academy for Public Health at UNC Chapel Hill. And in her not so copious free time, which I can attest to, she does not have a lot of free time. She enjoys playing competitive volleyball, recreational softball, and trying her hand at wildlife photography. So I will now turn it over to Kathy.
All right, well, good morning or good afternoon, depending on where you are. So as a telehealth resource center, I get lots of questions. And so my role in this webinar is to really help frame the issue. So next slide. I thought that the best way to frame the issue was just to take this whole issue from the perspective of both the patient and the provider. So in the Mid-Atlantic region where I am, I have many states that have these borders that are kind of fluid. People commute from one state to the other. They live in one state. They live and play across different state boundaries. And so in this particular scenario, I'm creating Leslie is a 39-year-old female. She has a child age 3 with a rare genetic disease. Leslie lives in Virginia. Leslie works in Maryland, where her work site has childcare. So Leslie and she also has family in Maryland who helps with childcare. So she basically brings her child to work or drops the child off at daycare. But Leslie's child gets care at the Rare Disease Institute at Children's National in DC. Now, this is hypothetical, yet it's very real because these are things that happen on a daily basis. So let's say Dr. Naeem, age 41, is a specialist in medical genetics and metabolic disorders, and he has a license in DC. So if you see this map right here, this is the metro map for DC, Maryland, and Virginia, and you can see very obviously how fluid things are. You can, with a very simple train ride or a couple of changes, be in one state to the next within 5 minutes, 10 minutes, or 20 minutes. So that is, those are the boundaries that we kind of live in our daily lives. And in the states that I work with, we have similar situations with New Jersey and Pennsylvania, where crossing the bridge is, a 5-minute ride and you're in the next state. In the rural areas, we have Kentucky, West Virginia, North Carolina, all who have borders, and they share practices and practice sites that sometimes are across border, sometimes are in one border, but patients have fluid lives, and so they're going across borders. So the next slide. So from the patient's perspective, the reality of it right now is that the doctor or physician or practitioner, the rule of thumb is that the practitioner needs to be licensed where the patient is physically located at the time of service. So our patient here, or the mom of the patient, basically can drive or take her child via metro into DC from Virginia, where she lives, or Maryland, where she works, to be seen by Dr. Naeem. No problem. But if she wants her child to be seen by telemedicine by Dr. Naeem while she's at work in Maryland or while she's visiting family in Maryland, that's a no-no, because Dr. Naeem is not licensed in Maryland. If she wants her child to be seen via telemedicine by Dr. Naeem while she and her child are at home, that's also a no-no, because they live in Virginia and he's licensed in DC. So from the patient's perspective, it's, how does this make any sense? It's the same doctor. I can commute 20 minutes each way to get to his office to see him. I can literally drive 10 minutes across the border and do a telemedicine visit in a parking lot in DC, but I can't do a telemedicine visit from my house or my work site or my parents' house. And that is the challenge right now for many, many patients who often have a specialist or a doctor, or who oftentimes the nearest doctor is across the border and not in your own state. And so this is the enigma that we're all faced right now. So next slide. From the clinician's perspective, it doesn't make sense either, right? So if the patient lives in DC and the child is not feeling well, it's okay to offer telemedicine services. Like if they call and we go, okay, let's do a telemedicine visit. But the patient lives in Virginia and the child's not feeling well, we'll need to ask that family to bring a child into our office. Same thing with the patient who lives in Maryland. Ask that family to bring the child in. So, it doesn't make sense. And what I hear from clinicians all the time is, I just want to be able to offer the same array of services and the same level of care for all my patients. It shouldn't matter where they live. So next slide. So one of the things that I heard prior to the pandemic, and a lot of the pandemic flexibilities helped this a lot, but that has started to change back. From a clinician's perspective, they don't want the complication, and it is complicated, right? Like they say, my practice would offer telehealth to all my patients if it weren't so complicated. When a patient calls asking for a telehealth appointment, there are too many steps involved to figure out whether I can say yes or no. And this is just a small list of what they need to figure out. So if you have a patient on the line and they say, my child is not feeling well, can I have a telemedicine visit with a doctor? Suddenly you're going through this whole thought process. All right, so where do you live? Where are you going to actually be seen at the time of visit? What type of provider do you need to see right now? Does this provider type fall under some kind of interstate compact? Is the patient's state participating in the compact? Is this provider licensed in the state where the patient will be if there's not a compact? What kind of insurance coverage does this patient have? Does the payer cover telemedicine services? And if so, which provider types, services, and modalities are covered? Will the payer cover telemedicine services with an out-of-state provider? Are there consent requirements by the state where the patient will be, or by the out-of-state payer? And the list just goes on and on. And so you can see why many practices prior to the pandemic hesitated. They were like, I cannot, when all the stars align and I can tell a patient yes, then yeah, I would love to offer this, but I can't go through this rigmarole of decision points and having to go through this whole litany of items just to be able to say yes or no to a telemedicine visit. And this is the complexity. So many of the states in my region have worked at the legislative and policy level to try to make things easier. Many states have joined the various different compacts, licensure compacts. There's nursing and PT and psychology, and the list goes on. But then again, not all states are part of that compact, and you have to constantly be up to date as to which states are part of which compact. Some states have started some efforts to develop some policies where if it's a bordering state, they negotiate with that other state and they say, hey, if you have the same policies in your state and we have that in our state, let's just pass some legislation saying if it's a bordering state and patients are going across the border just to see a clinician, that it's allowable. And we have seen some of that happen. There's been some recent language that has passed around established patients. So if the patient already has an established relationship with a provider from out of state, so let's say, I bring my child to a geneticist in another state that they have had a physical one-on-one relationship, that's an established relationship, then telemedicine is okay because it maintains the continuity of care. And we have had other legislation that has failed because they've been too broad and providers and licensing boards have not been comfortable with it. So I think we're going to be seeing a proliferation of different pieces of legislation and policy to try to address this complexity. And it truly is a very complex issue for both patients and providers. So from there, the next slide is just my contact information. Happy to answer questions, but I think we could probably just jump into the rest of this so that you really can understand a deeper dive as to all the issues involved.
So just a really quick question for you, Kathy, or more sort of like clarifying. So you talked about, the licensure issue and consent issues as well. One of the big things also is around reimbursement, and not only the different policies around reimbursement, but the Medicaid, but also in the commercial payer side as well too. Again, and as a reminder, folks, if you have a question for our panelists, please type it in the Q&A function. So I know you have, you have 10 states in your
We have 9. Yeah.
You have 9 states in your region now. I mean, with those 9 states, can you give them the same answer for like all 9 states on anything related to telehealth?
Absolutely
as far
not.
as like reimbursement. And it's like a hard no. They all do it differently. And especially during the pandemic, they've all been kind of making adjustments to their policies as well too.
Yeah, and I think that is the complexity. Like, providers don't want to sit there and have to figure out every single little detail as to, what they'll get reimbursed and whether they'll get reimbursed if they say yes to telemedicine, and whether they'll get sanctioned by their licensing board. And all of those things just make it, sometimes it becomes a barrier, a hindrance to a provider saying, yeah, I'll do telemedicine. Oftentimes they'll just say no, like just say no, tell the patient to come in.
Yeah. I know I see Amy from my CCHP staff is typing in an answer, but I think this is a good question that maybe a lot of people might have on their minds. And that is what happens during like a self-pay patient, because we were talking about reimbursement with Medicaid and commercial payers, but what if they're paying out of pocket as well?
The self-pay patient doesn't have the restrictions in terms of whether they'll get reimbursed, because the provider will get reimbursed by the payment, but the licensing doesn't change with self-pay. So they're still bound by licensing restrictions. And if they're not licensed in the state where the patient is, they can still be sanctioned.
Yeah. So as a reminder to folks, even if you're getting paid, the telehealth policies are there for payment as far as like the Medicaid program or commercial payers. There's a host of other policies that you're going to have to like be aware of when you're trying to provide services in another state. Thank you, Kathy. And Kathy will be back with us towards the end, but we are going to move over to our next speaker, who is Kim Horvath. And Kim is a senior attorney with the American Medical Association in their Advocacy Resource Center. And she leads a multifaceted advocacy campaigns across the 50 states on top-level healthcare issues, including scope of practice, telehealth, physician-led team-based care, physician licensure, workforce, and truth in advertising. Kim works in strong collaboration with the 50 state medical associations and national medical specialty associations across the country to help shape and inform state laws, regulations, and policies in support of patients and physicians. Kim has advocated before national policy-making organizations, state legislators, and state regulators. And I turn it over now to Kim.
Thanks so much, May. It's great to be here and happy to discuss this issue. Next slide, please. So first off, I think it's just important to say I'm going to really focus on this from a physician perspective, but a lot of what I'm going to say can be applied to other healthcare professionals. I'm going to try to answer 3 common questions today. First, do I need a license to practice medicine in the state? Second, is there an exception to that requirement based on the type of care that I'm going to provide? And third, if the answer to that is no, how can I obtain a license to practice telehealth in the state? And based on Kathy's presentation and the second set, the 2 questions after the first that I think you already know the answer to the first question, which is that physicians, generally speaking, need a license to practice telehealth in the state where the patient is located. And this is pretty much true across the board. That said, there are some exceptions to the licensure requirement, and Kathy touched on these just a little bit, and I'll just take a moment to expand. If you can, next slide, please. So there are some exceptions based on the type of care provided via telehealth. So I'll start with the 3 most common exceptions, and these were in place prior to the pandemic. And the first is for an emergency situation. So in the event of an urgent or emergent circumstance, a physician can provide care to a patient via telehealth, even if that patient is located in another state without being licensed in that state. Another common exception, again, prior to the pandemic, this was also the case, is physician-to-physician consultations. So if a physician is providing consulting services to another physician who maintains the patient-physician relationship with the patient. That consulting physician does not necessarily need to be licensed in the state where the patient is located. And the third is for care provided on an infrequent or irregular basis. Some states have taken steps to actually put language either in statute or regulation specifying this. And in doing so, sometimes specify what kind of this entails, whether it's a certain number of services that they can provide or to a certain number of patients over a period of time that would meet this exception. And I'll note here that the Federation of State Medical Boards recently adopted updated version of their telehealth guidelines for state medical boards. And within those guidelines, they include an exception to infrequent care provided across state lines as a potential exception to licensure. Some of the other ones that I want to address are ones that have been, we've really been talking about since the pandemic. I think there have been a realization that other exceptions are warranted, and these have really been discussed in some of the policy circles. So first off, follow-up care for an established patient. So this would be where a physician licensed in state A provides care to a patient who happens to have traveled to another state, whether it's for college or for work, or maybe they're on an extended vacation or just a regular vacation. That physician would be permitted to provide follow-up or ongoing care to their patient that they have an established relationship with if they are in state B without obtaining a license in that state. This exception would promote and allow for continuity of care and make sure that patients continue to have access to the physician that knows them best. And again, I think addressing some of what Kathy was talking about in her presentation. And again, speaking to that, I think during the pandemic and since the pandemic, there have been a number of studies that have looked at utilization of telehealth. And from those, we know, for example, based on a 2021 survey that the AMA did, they said that 63% of respondents reported that 75% or more of their virtual visits were with a patient with whom they had an established patient-physician relationship. And similarly, those numbers align with a study recently published in JAMA Health Forum, which found that 62.6% of all out-of-state telehealth visits were following a prior in-person visit between the same patient and clinician. So as long as that is follow-up care or for ongoing care or care that is being modified, again, there are some discussions about allowing that as an exception to licensure. AMA has policy supporting this. We do have language in our model telehealth legislation that includes this as a potential exception. It's also one of the exceptions provided in the model guidelines for the appropriate use of telemedicine technologies that I mentioned that FSMB, the Federation of State Medical Boards, recently updated and adopted. It's also included as an exception in a Uniform Laws Commission model telehealth bill as well. And a couple of states have actually already taken action and have enacted legislation that would provide and allow this exception, including Alaska, Ohio, and Virginia. And some of these states have specific time parameters. So for example, in Virginia, the patient must be seen in person within the last 12 months. Another common exception that's being discussed is for specialty assessments. It's a slightly different scenario than the physician-to-physician consultation. So this would be if a patient is proactively seeking consult or an assessment from a specialist in another state. So again, in that scenario, under this potential exception, a physician, that specialist physician would not need to be licensed in the state to provide that specialty assessment to that patient. If the patient was going to seek follow-up care, not follow-up care, but seek care, whether it's surgical or treatment or a procedure, often in most cases, they would travel to the state where the physician is located anyway. But for that initial consult or assessment, that could be done without the physician being licensed in the state under this potential exception. And this type of exception is included in the FSMB model guidelines and the Uniform Laws Commission model bill. And finally, I included clinical trials as well. I haven't seen any laws or regulations on this yet, but again, it is one of the exceptions included in the FSMB guidelines, so I wanted to add here. And for all of these exceptions, I think it's really important to note two things. First off, the physician still needs to meet the standard of care. So if the care that is being sought would not be appropriately provided via telehealth, that physician should be ready and able to refer their patient to local care, to a physician in the state where the patient is located, to make sure that they get the care that they need. And kind of the second important thing to note is that even if a physician meets these exceptions, they still need to comply with the Medical Practice Act laws of the state and other states' laws of the state, again, where the patient is located. So this exception would just be for licensure, but not the other laws of the state. And Jeremy's going to go through all of that, so I'm not going to do that now, but just know that those are really important to remember. So if the physician is providing telehealth care across state lines, the care provided does not meet one of these exceptions, the physician will need to obtain a license to practice in the state where the patient is located. There are various ways that a physician can do this. First, the traditional path. Physician can always go through the regular path set up by the state medical boards to obtain a license. The second is through a compact. And compacts have definitely grown and have become more, there's a number of them for not just physicians. The physician is the Interstate Medical Licensure Compact, but other healthcare professionals have compacts too. There's a psych pact for psychologists. There's a nursing compact as well. And they all operate a little bit differently. But in terms of the Interstate Medical Licensure Compact, that compact, there are currently 37 members, states, plus DC and Guam. And how it works is if a physician lives in a state that is a member of the compact, they can use the compact to facilitate obtaining licensure in any of the other compact states. And it just provides a more expedited, streamlined process for them to do so. And in doing so, they do obtain a full license to practice medicine in those states. It is not specific just to telehealth. And I'm sorry, my dog is now barking in the background. I'm sorry if you can hear that. The other types of ways is that states are looking at is creating a registration or a special telehealth or telemedicine license. And both of these are a little bit similar, so I'll talk about them together. A couple states like Arizona, Florida, Maine, and Minnesota have created a telehealth registration process. Maine's notably is limited to consultative services, but basically what these offer is a path for physicians to still register with the state medical board to provide telehealth in their state. But it is limited only to telehealth. The physician cannot provide care in person in the state. They cannot open an office in the state. And they often have to comply with other requirements like in Florida, the physician, or actually Florida is for a variety of healthcare practitioners. So the healthcare practitioner must, for example, obtain a registered agent in the state to be there to receive if there's service of process or other important documents provided. They have to retain that registered agent in the state. They also have to have liability coverage based on the state requirements of Florida as well. And some of the other states have similar requirements. The special telehealth licenses work somewhat similarly. Georgia, Louisiana, and Vermont are some examples of states that have set up a special telehealth license. Again, similar to the registration process, often limited to telehealth, obviously by the name, but often also it specifies that a physician cannot open practice in that state or see patients in person in the state. Vermont kind of took the tact, a hybrid approach. So they have both a special telehealth registration process and a special telehealth license. And it really, for them, it depends on the number of patients that the physician is going to see and the time frame. So for example, the telehealth registration process is for a healthcare professional that provides telehealth for no more than 120 consecutive days from the date that the registration was issued, and they can only provide telehealth services to no more than 10 unique patients. The registration can be renewed once every 3 years, but so it is limited. If a healthcare professional is going to see more patients than that, they can apply for a special telehealth license that allows them to see no more than 20 unique patients over a 2-year period. And that license can be renewed every 2 years. So they ended up taking a little bit of a hybrid approach. A waiver process is what we saw a lot of during the pandemic. States just waiving the licensure requirement because we wanted, at that time, we wanted to just really, we weren't sure the pandemic is going. We wanted to make sure that if healthcare professionals needed to get to another state, they could quickly without the licensure process delaying their ability to provide care in that state. Similarly, again, as patients were shifting, as college students were going home, we wanted to make sure that patients had access to their physician that they had, you know, in the state that they were previously when they maybe traveled back home. Most of these waivers have expired. I will note that Kansas has a process. They do have a telemedicine waiver. It's a little bit similar to a registration process or a special telehealth license in the sense that the physician still needs to apply for the waiver to provide care to patients in the state. Pennsylvania has a waiver that is set to expire at the end of October, but is technically still in place. And not specific to telehealth, but Kathy kind of mentioned this, so I wanted to just plug in here that Pennsylvania offers an extraterritorial license for providers licensed in contiguous states if they meet certain requirements. So some states are looking at that as well. And then I put in here volunteer license. Again, this has been in place for a while, but if patients or physicians or other healthcare professionals are providing telehealth services across state lines in a volunteer capacity, that is another pathway for them as well. I will stop there and turn it back over to May.
Thank you, Kim. Sorry about that. My controls there went a little bit crazy for a second. So just wanted to make clear in case there was any confusion or somebody may have missed this, those exceptions you listed, Kim, those are not commonplace throughout, like, you know, a lot of states. They are examining whether to like institute some of those exceptions, though a couple of states have done some of them.
Yeah, thanks so much, May. I'm glad you made that really clear. And those are kind of discussions that are happening in the policy circles. I think, what did I say? 3 or 4 states have the one exception for follow-up care, but definitely something that we haven't seen a lot of states move in this area, but is definitely something that is being discussed in policy circles.
Okay. Before we move on to Jeremy, I'm going to take one question from the audience. I don't know if you can answer this, Kim. It is about the Interstate Medical Licensure Compact. Does it apply only to physicians who are licensed under IMLC, or does the IMLC requirements such as investigations, discipline, etc., apply to all physicians in the states that have adopted the IMLC?
So good question. So the IMLC is simply a way in which it provides an avenue for physicians to seek licensure in the other states. So the state medical practice acts and laws of the states that exist within the compact still, they're set as is. So if a physician is a member of the compact or if a physician's state is a member of the compact, they can use the compact to obtain a license in other states. But the compact doesn't set the licensing parameters. There are parameters that a physician needs to meet in order to be able to be licensed through the compact, but the compact doesn't issue the license. It's the individual states that issue the license. And a physician through the compact can select which states he or she wants to be licensed in through the compact.
All right. Thanks a lot, Kim. We will have you back after Jeremy's presentation. Up next is Jeremy Sherer, who is a partner in the Boston office of Hooper, Lundy, and Bookman, and co-chair of the firm's digital health practice. Jeremy is a nationally recognized telehealth expert who represents healthcare providers and suppliers, including hospital systems, provider organizations, national telehealth platforms, and digital health startups on issues involving regulatory compliance, transactions, and innovative business arrangements. So I will turn it over to Jeremy.
Thanks so much, May. Thanks for having me, and thanks to everybody here for tuning in. In terms of what I'm going to cover here, I've sort of been tasked with running through sort of the checklist of state-specific legal issues that one needs to think about when providing care across state lines. What are the different things that might be different? What do we need to think about when deciding to provide care across state lines? So I'm going to do my best to explain all of that in 10 minutes or so. We'll see how we do. Next slide, please. So this can serve as sort of a rudimentary checklist of sorts, and is really kind of the roadmap for what I'm going to speak about today. And then there's another slide after this focusing on controlled substances prescribing, which is sort of a topic du jour, if you will, in that it's a very important issue. Particularly confusing right now because of the public health emergency, waivers of certain federal laws, and the interplay between federal and state law. So we'll get to that as well. But for now, I'll just run through these really core legal concepts and issues that folks need to be thinking about, because given, as Kim and Kathy have already mentioned a bit, we in this country, we have 50 states, and there are 50 different, and there are 50 different legal landscapes that one needs to navigate and be familiar with when providing care in those jurisdictions. So, of course, step one is licensure. That was what we spent the most time working through on the ULC model telehealth laws project. It's what there were the most comments on the FSMB guidelines, and it's sort of step one. I'm not going to spend too much time there because Kim already did a really great job outlining the core considerations there. The one thing that I will just reiterate, because, and again, Kim did a great job running through the many, many details and different iterations of exceptions and the way that things can look different from one state to another. The one thing I just want to reiterate there is that this is very much a state-by-state analysis, that there are certain flavors, types of exceptions that are common for established patients or for infrequent or occasional consults. But it really is important that you're always checking the laws of the state in which the patient is located when services are provided. It is the laws of that state which will govern. And again, every state is different. As to prescribing, so like everything else that we're talking about here, every state is different. One thing that's interesting about prescribing is that the Federal Controlled Substances Act does address prescribing of scheduled controlled substances. For the most part, when you're dealing with the practice of medicine or other regulated professions, all legal authority is going to exist at the state level because it's those states which license and regulate the practice of those professions within the state's borders. Prescribing is an exception to an extent because there are federal laws addressing those issues, but they have to work together with state law. Generally speaking, in non-pandemic times, state law is where we'll look for prescribing rules regarding non-controlled substances, and federal law is the standard regarding those controlled substances. Right now, it's a bit of a confusing situation, a bit of the Wild West, if you will, with regard to prescribing, but we'll talk about that in a moment. The corporate practice of medicine doctrine is an important legal concept to understand and to consider when you're providing care via telehealth across state lines. About half of the states in the US have corporate practice of medicine prohibitions. California, New York, Texas, North Carolina are some examples of some of the stricter corporate practice of medicine states. But basically, it's a legal doctrine that is typically rooted in case law, and it stands for the proposition that in order to protect clinicians from the corrupting influence of business, that only professionals, either if we're talking about physicians, either professional medical corporations or individual physicians themselves can contract with or employ other physicians to provide medical care. And the idea is that others with the professional background of that physician will have the same patient-centered clinical considerations in mind, as opposed to folks maybe on the business side of an arrangement who might be more concerned with the bottom line and business considerations than the underlying clinical care. The reason this is important here is because it really informs the structures that need to be in place for professional services arrangements in states with corporate practice of medicine prohibitions, including when that care is provided via telehealth. And for folks who are in brick and mortar facilities and in the brick and mortar world in a state like California or New York or North Carolina, where there's a strong corporate practice prohibition and it's well known in the medical community there, folks understand these issues and are used to contracting with professional corporations for professional services. The place to be careful is when, now that we've seen this great proliferation of telehealth and the delivery of care via telehealth, oftentimes medical groups will move across state lines to provide coverage, to handle a provider shortage of a particular type. Behavioral health is common, for instance. And if you're located in a corporate practice state and the patient is located in a corporate practice state, let's take New York as an example, and a New York medical group or facility is contracting with some physicians who are licensed in New York, but physically located in Virginia. To take one of Kathy's states, Virginia is a state that doesn't have a corporate practice of medicine prohibition. And so as a result, there can be situations which arise where you'll have a business arrangement which is structured in such a way that the medical group in Virginia might be used to contracting for professional services through a lay entity, through a C corporation, which is allowed under Virginia law, again, because there is not a corporate practice of medicine prohibition there. But once those clinicians are providing care in New York, it's the laws of the state of New York which govern. So it's particularly important when you're contracting across state lines to make sure that, to the extent you're in a corporate practice state, the right type of entity is contracting for those services. As far as modalities go, it's really 5 or 6 years ago, there really was still the question of, well, can we establish a practitioner-patient relationship via telehealth? That was addressed in pretty considerable detail in 2017 in litigation involving Teladoc and the Texas Medical Board, and we're now comfortable that a practitioner-patient relationship can be established via telehealth across the states. The question now is, what does telehealth mean? What does that look like? And what I mean by that is a synchronous audio video interaction like we are having now, or at least among the panelists right now, we're having, that can be utilized to establish that practitioner-patient relationship. But what about store and forward technology, which refers to a scenario where, to take dermatology, for instance, a patient captures clinical data in the form of a picture of one, let's say of one's face, to capture acne symptoms, sends it to a clinician who's located remotely at a distant site, and that practitioner can then review that photo on their own time and follow up with the patient, make a diagnosis, figure out a course of treatment. Most states do allow a practitioner-patient relationship to be established using store and forward technology where it's clinically appropriate, but it's important to check. There are also questions now with the rise of platforms which are providing care via synchronous chat. We're all used to talking on Teams and Slack and whatever else during the day, and there are states which do allow practitioners to establish practitioner-patient relationship using that live chat function. But it's really important to check. And of course, like everything else we're talking about here, it varies state by state. As far as ID verification and patient consent, these are examples of issues where there's quite a bit of variation among the states, even as to the question of whether they address it at all. There are plenty of states which do require a practitioner when establishing a practitioner-patient relationship or providing care via telehealth generally to view an ID of the patient to verify that the patient is who they say they are. Similarly, there are plenty of states which require providers to obtain the patient's consent to receive care via telehealth before beginning a telehealth appointment. This is another issue to check state by state. I will also note that even in states where it is not required to do the ID verification or to obtain consent, these are still things that are generally thought of as clinical best practice. So for many of my clients, even when they're working in states where these things aren't technically required, they'll still do them anyway as part of the workflow, just in the interest of clinical best practices. Others have mentioned reimbursement is obviously something that can vary quite a bit. The Medicare program, in terms of its reimbursement standards, won't change state by state because it's a national program, but every state Medicaid program does cover telehealth differently. And it's important that when you're providing care to a beneficiary of a state Medicaid program, you ensure that you are providing that care in accordance with that state Medicare program's conditions of participation and coverage. I won't spend more time on that because Kathy and May and the CCHP folks at large are really the experts in that area. Credentialing is another important issue that comes up when you have arrangements that involve the provision of care across state lines. It's less and less the case, but there historically have been some states which don't allow for proxy credentialing, which refers to a situation where anytime a clinician is providing care at a hospital, typically they need to be a part of that hospital's medical staff, and there's a credentialing process to become a member of that medical staff. Particularly if you have a clinician who is only providing a few episodes of care via telehealth, that can be a really long and exhaustive process. Proxy credentialing refers to relying on the credentialing process of the distant site facility, so the facility where the practitioner is when they are providing care to a patient at the originating site, which is the hospital facility where the patient is located. That is something to look at under state law. In addition, we talk a lot about the licensure of practitioners and making sure that we're abiding by state law concerning licensure. It's also important for non-physician practitioners, whether it's in some states, nurse practitioners or advanced practice registered nurses, physician assistants, and others who need to be supervised by a supervising or collaborating physician, ensuring that when those non-physician practitioners are providing care across state lines, that they are being supervised by a physician who is appropriately qualified and licensed to provide that supervision. The last thing before moving to the controlled substances prescribing issue is malpractice coverage. It's really important when crossing state lines and providing care via telehealth to ensure that, one, the malpractice policy that's covering that provider covers care that's provided via telehealth, and two, to ensure that that malpractice policy also applies in the state where the patient is located. Even if the provider is located here in Massachusetts, where I am, and the patient is located in New Hampshire, it's very important to ensure that the Massachusetts practitioner's malpractice coverage applies to services that are provided in New Hampshire, because those are the laws that will govern with regard to that episode of care based on the location of the patient. Next slide, please. So I'll go through this quickly, and hopefully these slides will be available to folks, but I'm getting a lot of questions on this right now. And as I mentioned before, controlled substances prescribing is an area where you're going to have an overlap between federal and state law. But it's also important to note that in addition to addressing legal requirements around the question of whether a practitioner can prescribe controlled substances in that state via telehealth without first performing an in-person examination of the patient, in general, there are also requirements for state-specific controlled substances registrations at both the federal and state level. So the Controlled Substances Act, which is a federal law as amended by the Ryan-Haight Act, prohibits prescribing controlled substances via telehealth unless one of a series of exceptions is satisfied. And those exceptions are really geared towards the sort of brick and mortar context. And while they are known as practice of telemedicine exceptions, they don't capture a lot of the care that is provided via telehealth today. In particular, they're not designed in such a way to allow patients to receive this treatment from the home, for example. One of those exceptions is that there is a public health emergency in place. And so right now, those provisions of the Controlled Substances Act are waived for the duration of the public health emergency. We don't yet know from the DEA what the status of those rules will be post-pandemic. In particular, there's a special telemedicine registration process that was written into statute and was clearly envisioned and was meant to be implemented back when the Controlled Substances Act was amended in this way back in 2008, 2009, but to date, it hasn't happened. And so there are questions about whether the DEA will hopefully establish that telemedicine registration process now. Federal law aside, there are also state laws which address controlled substances prescribing. So it's important to understand, particularly now when those federal laws are waived, that you understand state law. And states fall into different categories on this. Some states completely defer to federal law. So if you're in compliance with federal law, you're fine. State law can't require less than federal law. The federal law acts as a floor, but states can require more than the federal law. So there are some situations where you have states which are more restrictive with regard to controlled substances prescribing laws than the Controlled Substances Act. And at both the federal and state levels, there are also practitioner-specific and state-specific registrations that you may need to obtain. At the federal level, it's required that in addition, if a practitioner wants to be able to prescribe controlled substances in all 50 states, they also need to have a federal controlled substances registration specific to each of those states. At the state level, about half of the states are what's called two registration states, meaning that in addition to that federal registration, they also require a state-specific controlled substances registration. I believe that's it for me. Let's see if I'm surprised. Nope, that is it for me. My contact information is there. I'm more than happy to take any questions now, or folks can feel free to follow up with me afterwards as well.
Thank you, Jeremy. We're going to take one or two questions for you, and then I'll ask Kim and Kathy to come back. Very quickly, from James Sharp, does the 151-day extension of the federal PHE under the Budget Act of 2022 extend the Ryan Haight Act as well?
No.
And James, there's your very quick and definite answer there. You know, I don't know if you have an answer for this, but this is from Hamza Rehman, and I apologize if I pronounce anybody's name incorrectly. How is state credentialing different than licensing, or credentialing a requirement for payer reimbursement only?
Well, there are certainly credentialing requirements for payer reimbursement. When in the context I was talking about credentialing in was actually specific to healthcare facilities. So when you're receiving care at a hospital, there typically in the hospital's bylaws, there you'll have a pretty detailed process outlined for becoming a member of the medical staff, and not just anyone. You'll hear clinicians talk about having admitting privileges or privileges at a hospital, whether they're able to provide care at that facility. As far as state laws regarding credentialing, there's nothing that's coming to mind for me right away, except that some states will allow for proxy credentialing and other states will not. Although again, there are fewer and fewer states which are expressly not allowing proxy credentialing. I hope that answers the question.
Okay. And if it does not, if you want to type in another question as a follow-up, go ahead and do that in the Q&A. I'm going to ask Kim and Kathy to come back because we've got quite a few questions in here. And I'm just going to throw them out there to see who would like to tackle it first. There's actually a lot of questions regarding supervision and how does that work with telehealth when you're crossing state lines? Are there a lot of policies specific to telehealth and how that work if you're doing supervision of like other staff and using telehealth?
So in general, supervision requirements vary from state to state. So you do need to be careful, especially if you're crossing state lines, about what those state policies are. But also in general, if you are seeing a patient in, let's say, Maryland, and you are a trainee in, let's say, DC, your supervisor actually needs to be licensed in Maryland to be able to supervise you because that's where the patient is located. And so the rules of that state apply.
There are quite a few questions in the Q&A regarding prescribing and what happens when, say, the patient is traveling for vacation or something like that. And I think, and they vary. There are questions also for on controlled substances or non-controlled substances. What do you do in a situation where the patient is, again, maybe on vacation or they're a student and they are trying to get a prescription, either a prescription renewal or a, maybe a new medication needs to be prescribed to them that the telehealth provider has has decided needs to be done in that particular situation. So Jeremy, I don't know if you want to tackle this one.
I mean, it's certainly the case with regard to when you have folks that are traveling, if there's an examination that is taking place, the practitioner needs to be licensed in the state where the patient is located. If there's a refill that can be issued in a clinically competent way, which doesn't require a subsequent exam, it wouldn't be as a creature of state law that the practitioner would need to be licensed in that second jurisdiction. My only hesitation is with regard to state pharmacy laws, which are different.
And I'll just add that the State Medical Practice Act might have some specifics there as well that a physician would need to look at. I'm not sure about the other healthcare professionals.
So I'm just going to do a blanket apology when we say it's going to depend on the state. It really does depend on the state. There's like really very few sort of like, oh, this is what it means for everybody. So it is very complicated. We're just trying to highlight the issues for you so you're aware of these issues and you don't inadvertently like take a misstep because you just weren't aware of some of these issues that are out there. Kim, I don't know if you have an answer to this, or maybe Jeremy. Can a physician employed by a federally recognized tribe practice across state lines? They also added, are there exemptions due to the relation with Indian Health Services?
Probably.
Yeah, I think it depends if it is on tribal land. I think that's sort of like the significant factor that needs to be involved in that situation. If it's a tribal member and the services are taking place in tribal land, they have a little bit more leeway to do that, as opposed to if, they were not on tribal land and they're just at home or something or at their workplace.
I think the other blanket exception is for VA. So VA providers can go across state lines or even go across country lines.
Okay, this is from an anonymous attendee. Do states need to specify telehealth in statute to provide care if no setting venue is specified in the statute? Can it be assumed that telehealth is included if venue setting is not specified in statute? Trying to sort that question out there myself. I think this may be related to more of a reimbursement question, because it is in statute that you see a lot of that specificity around location of like the patient, as opposed to things like around licensing or like consent. So I think they are asking if there is need to like have telehealth connected with like the patient location. So if the person is asking about commercial payer laws, sometimes it's very rare though. So it's very rare that a commercial payer law will specify the location of the patient. They may say something like, you can't like do you can't like not include the home or something. So there's usually like not a list that they do in commercial payer laws as far as like location of the patient. But again, it's going to vary from state to state. I think there are like a couple of states that do that, but for the most part, most of them don't. Let's see. We were, I don't know if Edward Lee might have some more information. He said, we were told the public health emergency extension meant that Ryan Haight was still in effect through January. I did not see that in the Budget Act, but I don't know if DEA has.
So we're talking about two different things here. So as long as the public health emergency is in place, the DEA's waiver of the Ryan Haight Act provisions of the Controlled Substances Act and the state-specific controlled substances registration requirement are waived. The public health emergency was last extended through January. So until that point, we know that those those authorities will be waived. The question we got before was about the 151 days after the public health emergency, which is the period during which we know from Congress that for at least that period, the flexibilities regarding telehealth and the Medicare program will be extended. But that 151-day period did not also reference the waivers of the Controlled Substances Act as amended by the Ryan Haight Act. Now, I will say, this is something, the DEA knows that this is an issue. And I would be surprised if we didn't have some sort of off-ramp when the public health emergency ends. And there are different ideas floating around, and there are different discussions in policy circles about how we're going to treat, for instance, patients who established a practitioner-patient relationship via telehealth during the pandemic, which involved treatment involving controlled substances, that perhaps they will effectively be grandfathered in until a more permanent solution is identified. But so for the duration of the public health emergency, yes, the waivers are in place. The question is about that 151-day period after the end of the public health emergency and more broadly into the future.
Okay, we are at time, but there is one question that we wanted to hear your thoughts on. It's very quickly. There's a couple of people in here have commented in the Q&A saying, like, this is so complicated to navigate. What's the best way to approach it? So any advice you can give just in general on the best way to approach it?
I mean, one thing, if there's a question on a specific state, is to reach out to for physicians to reach out to the medical board of that state to ask the question. Again, that's for a specific state, but that's one way to handle it if there's a lot of questions.
CCHP and telehealth resource centers.
Exactly. Shameless plug.
And that, sorry.
Yeah. So we do, the telehealth resource centers can help you on like sort of your initial questions. I will also say, you know, and definitely like the medical board, if you are a physician or any type of licensure or regulatory board in operating in that state, just definitely contact them. If you want to go deeper and you do want like the assurance of having like a legal opinion, consulting with attorneys such as Jeremy and other folks who operate in the telehealth field with their practices as well, is always a good thing too. If you have a legal department within your organization, consult with them definitely on some of these issues. We are at time. I knew this was going to be a robust discussion. There was going to be a lot of questions, so I apologize that we couldn't get to all of them. I will download all your questions and like go through them. If CCHP can't answer them, we'll consult with Kim and Kathy and Jeremy to see if like they can give us a question there or an answer there. Thank you, everyone. Just very quickly, I'm just going to share the screen again, just for some final details here. Thank you to our panelists, Kathy Wibberly from the Mid-Atlantic Telehealth Research Center, Kim Horvath from American Medical Association, and Jeremy Sherer from Hooper, Lundy, and Bookman. Please know that this webinar is being recorded. This and the slides will be made available on the CCHP website a couple of days after today. We also have a newsletter if you would like to subscribe to that as well. You will be sent an evaluation form when this webinar is over, so it would really help us out if you could fill that out and send it back in. It's very short and it'll only take you 5 minutes at most. Next week, we are going to be looking at federal telehealth policy issues and what we need to be aware of moving forward. We have confirmed John Gordon, who is from the Office of the Inspector General. I will be talking about some of the Medicare policies and where we may be going with that. And we have tentative right now, but we have PCORI to talk about some of the research that they have been doing around telehealth during this time period as well. So thank you again to our panelists. Don't forget to fill out your evaluations, and everyone have a great day. Thank you.